Decision making in HCC is slightly more complex than all other cancers because all other cancers decision making involves two factors: the tumor factors, tumor stage and burden, patient factors like patient comorbidities and performance status. In HCC, there is a complexly interrelated third dimension, that is the chronic liver disease per se, because the primary etiology which caused the hepatocellular cancer is also causing a chronic liver disease. It can be viral, alcohol, or NASH. Almost all patients of HCC are expected to have some degree of liver dysfunction. The two most commonly used guidelines worldwide for HCC are the Barcelona Liver Clinic Guidelines (BCLC) guidelines, which are more often used in the West and in Europe, and the HKLC guidelines, Hong Kong Liver Clinic Guidelines, which are more often used in the East, Japan, China, and Korea. We will be seeing that there is a wide variation in practice between the two geographic areas in terms of HCC management. In an interesting comparison between these two guidelines, it was found that the degree of agreement between the two guidelines was close to 80% for the earlier stages and for the late stages, whereas for the middle stages, the BCLC B and C, the degree of agreement between the two was low. In our discussion, we'll be moving from right to left, that is, from the most advanced cases to the earlier cases, both in BCLC and HKLC. And we'll also be focusing more time on BCLC B and C, that are the controversial areas, rather than the relatively straightforward BCLC 0A and D. Now, in BCLC D is a patient with end stage liver disease or a very poor performance status. If a patient's performance status is 3 or 4, obviously no cancer directed therapy is possible in that patient. And if a patient has a child CCLD with a hepatocellular carcinoma that fits within the Millen criteria, and in some countries expanded criteria also, the patients can be enrolled in a transplant waiting list. And this transplantation is aimed at treating the chronic liver disease per se rather than treating the hepatocellular cancer. The patients may not get an additional preference in the waiting list just because they have developed hepatocellular cancer. And this too, as long as the AFP is less than 1000 or 500 in some countries, so that the patient's tumor biology is not very significant of a high risk of recurrence in the transplanted liver. BCLC-D, if a patient with BCLC child CCLD has HCC beyond the acceptable criteria for transplantation, or if the patient has extrahepatic disease, the patient is offered only best supportive care apart from management of the chronic liver disease. And these patients should not be considered for enrollment in transplantation waiting list because of their extremely dismal prognosis and a very short life expectancy. Now, we have come to BCLCC. BCLCC has two different patients. One is patients with extrahepatic spread, lung mets, bone mets, etc. The other is a group of patients with portal invasion. Now, for patients with BCLCC that is extrahepatic, as long as their chronic liver disease is less than child B7, they can be started on systemic therapy, because all the trials which tested systemic therapy included patients only with CTP less than B7 CLD. When the degree of liver dysfunction is more than this, patients do not tolerate systemic therapy. Now, in patients with BCLC-C, that is because of portal invasion, we see here that the BCLC guidelines give only systemic therapy as option. Very similarly, HKLC guidelines also give only systemic therapy as option. But these guidelines should be viewed as broad roadmaps that help us in decision making rather than rigid guidelines which should be followed verbatim. The reason why systemic therapy is given in both these guidelines is that we have umpteen level 1 evidence to support the role of systemic therapy in patients with BCLC with portal vein invasion. But is systemic therapy the only option for patients with portal vein thrombosis? The answer is no, because both HKLC and BCLC do not substratify patients with portal vein thrombosis. Whereas in the East, in the East, there are two classification systems which substratify patients with portal vein thrombosis: the Japanese VP classification and the Chinese Cheng's classification. Segmental portal vein thrombosis will be VP1. The second order branches, right anterior, right posterior portal vein will be VP2. The first order branches, the right or the left portal vein will be VP3. The main portal vein or the superior mesenteric vein will be VP4. Very similarly, the Cheng's classification also classifies into types 1 to 4, 4 being the most complex. Now, the other modalities for patients with portal vein thrombosis. We saw that systemic therapy, there is level 1 evidence and umpteen evidence. But what are the other options for patients with portal vein thrombosis? Many phase 1 and phase 2 retrospective analysis have given acceptable outcomes for radiation of the portal vein thrombosis, following which we analyze in a phase 3 randomized control trial evaluated patients with resectable HCC with portal vein thrombosis. They randomized the patients into two arms, neoadjuvant radiation followed by surgery versus surgery alone. And they found the overall survival was improved with the use of neoadjuvant radiation. TACE. The problem with TACE is that already because of the portal vein thrombosis, the portal supply is lost. Now, this segment of liver, this part of the liver is deriving its blood supply only from the hepatic artery. Now, if we block the hepatic artery also with a TACE, this portion can go into hepatic necrosis. This was the main concern of use of TACE in portal vein thrombosis. But Lee analyzed as early as 1997 in a prospective control trial proved feasibility of using TACE in patients with PVTT. Now, super selective TACE of just the feeder vessels for the tumor in patients with good liver function, with most importantly adequate collateral formation around the thrombosis, are considered ideal candidates for super selective TACE. Obviously, the more complex type 3 and type 4 portal vein thrombosis, that is the main portal vein or the superior mesenteric vein, they are not suitable candidates for TACE. With TER, the microspheres that are used are less than 60 in diameter, so they do not block the hepatic artery completely. So they do not alter the vascular dynamics as significantly as TACE does. So this was the proposed advantage of TER over TACE in patients with portal vein thrombosis. In a prospective non-randomized study, Salem analyze obtained a median overall survival of 16.6 months with patients with VP1 and VP2 portal vein thrombosis. However, the SARA trial did not reveal a survival advantage of TER over and above sorafenib alone. Now, is there a role for surgery in patients with portal vein thrombosis? We see that this patient has a thrombosis of the right main portal vein, but a stump is available. Why can't we just ligate the portal vein here and get away with the right hepatectomy? Just because we can do this doesn't mean we should do this, because the problem with patients with portal vein thrombosis is that it reflects a very aggressive biology, and also the risk of recurrence, intrahepatic recurrence in the remnant liver is very high. So at least in advanced portal vein thrombosis, upfront surgery should not be considered, but the concept of conversion surgery. For example, these patients can initially be treated with a radiation for the tumor thrombus or a tear or TACE, depending on institutional experience and patient factors. And then once the tumor thrombus is treated, once it disappears, and if the patient remains a good candidate for surgery in terms of liver decompensation and performance status, then we can consider a conversion surgery. In a Japanese nationwide propensity match analysis, median survival time of up to 3 years was found in patients who underwent surgery in patients with portal vein thrombosis versus 11 months who were treated only non surgically. So, conversion surgery should be strongly considered. Combination therapy. So, TACE alone offers a median survival time of just 8 months. Lee analyzed in a network meta analysis of 15 studies, evaluated all these treatment modalities for patients with PVTT, and they found that the combined use of radiation plus hepatic arterial based therapy like TACE or HAIC provided the best survival amongst all the regimens. Yoon analyzed in a randomized control trial also proved that the use of TACE, hepatic arterial based therapy plus radiation, offered a significantly better survival compared to sorafenib. So, this sorafenib or the systemic therapy being the recommended option for patients with PVTT in both Barcelona and HKLC. And in this RCT, TACE plus RT offered a better survival than this systemic therapy. Transplantation for patients with portal vein thrombosis remains experimental at this stage, though there are few reports offering good results. So, summary: If we have a patient with a BCLC HCC, that is because of portal vein thrombosis without extrahepatic disease, and if the liver functions are preserved, we first need to substratify the patients based on the extent of portal vein thrombosis. And for VP1 and VP2, that is the distal thrombosis, upfront surgery may be offered, though these patients have a higher risk of recurrence following surgery compared to the patients without PVTT. So, to tackle this higher risk of recurrence, adjuvant therapy in the form of TACE or HAIC or systemic is considered. For VP3 and VP4, that is the more proximal tumor thrombus, some neoadjuvant therapy and conversion surgery should be considered. Now, we have moved on to the next section, that is BCLC-B, which is multinodular, that is beyond BCLC-A. BCLC-A is up to 3 nodules. The largest nodule cannot be more than 3 centimeters. Anything beyond that, that is multinodular, is considered BCLC-B. Now, as we can see from these examples, all of these 4 examples are BCLC-B. These are not everything, there can be more examples. It is a very heterogeneous group. Starting from this patient who maybe all the lesions may be resected with an upfront right hepatectomy to this patient who has diffusely infiltrative bilobar disease. So all these cannot be put under the same basket of BCLC-B. So treatment decisions have to be individualized. So the options that are, as we saw earlier, that the agreement between BCLC and HKLC in BCLC-B was very low. In BCLC offers transplant or TACE or systemic, and HKLC offers resection or TACE for patients with this group. So we'll evaluate each of these parameters in detail. Transplantation can be considered for patients with BCLC-B as long as they fit in some expanded criteria beyond the Millen criteria. But we have to remember that farther we move away from the criteria, higher is going to be the risk of recurrence. AFP is used as a surrogate biological marker. Higher the AFP, higher is the risk of recurrence. An arbitrary cutoff, not based on any level 1 evidence, of 1000 is used as a contraindication. More than 1000, liver transplantation is contraindicated. And if a patient who does not fit into any of these expanded criteria initially, and he received some systemic therapy or a neoadjuvant therapy, liver directed neoadjuvant therapy, and he was downstaged to the expanded criteria or the Millen criteria, then these patients should be considered for transplantation because it reflects a good biology of the tumor. Systemic therapy for BCLC-B, again, BCLC-B, the first option that is recommended is multinodular, so TACE. Now, when we are considering systemic therapy, we also have to remember that there is an important concept of treatment stage migration. That is, the treatment that is best suitable for a more advanced disease is offered for this patient because of a lot of other factors. So, there are no definitive criteria for this, there's no level 1 evidence. An expert assessment is required. I'd like to re emphasize that most all cancers benefit the best with MDTs, but especially hepatocellular cancer, because of the complex interplay of multiple factors, they are best treated by expert MDTs treating high volumes of patients. So, in an expert MDT, if patients with diffuse infiltrative disease, extensive bilobar involvement, or portal hypertension, which would contraindicate surgery, are seen. For example, patients like this, or patients with portal hypertension, they can be considered for systemic therapy rather than for TACE. Again, TACE would also be contraindicated in patients with portal vein thrombosis, portal hypertension. What is the role of surgical resection for patients with BCLC-B? Here we can see that BCLC does not even consider resection in this group of patients, whereas HKLC, though this is not a very similar group of patient, it considers resection for patients with less than 5 centimeters or more more than 5 centimeters with less than 3 nodules and all that. So the role of resection in patients with BCLC-B is more often seen in the East and in India. TACE offers a 5-year survival of only 20% in BCLC-B, whereas surgery offers a 5-year survival of 35 to 42% in patients with BCLC-B, seen in a variety of studies. So this was a meta-analysis of high-quality studies by Wang and Alice, including a randomized control trial by In and Alice. All the trials favored surgical resection over TACE in patients with BCLC-B. So this was a systematic review by the team from Tata under Professor Mahesh Goelza and allies by Dr. Sania Pandrawala. Literature comparing resection with TACE from 27 studies, almost 6,000 patients who underwent surgery, 7,600 patients who underwent TACE. All of these studies, except one, suggested that resection improved survival compared to TACE. So, the take home messages in patients with advanced HCC like beyond BCLC A, BCLC B, multinodular, or in sometimes in patients with BCLC C with portal vein thrombosis, surgery seems to offer the best overall survival, and surgery should strongly be considered, though not in the upfront setting. Somewhere down the line, a conversion surgery should be considered. If we come to the last section, BCLC-A. BCLC-A is a solitary tumor of any size. This is also BCLC-A, this is also BCLC-A. Or less than 3 nodules, each less than 3 centimeters. This is also BCLC-A, this is also BCLC-A. So as we can see, this is also a very heterogeneous group. All of them cannot be put into the same basket. So to choose, we see that both BCLC and HKLC have a lot of agreement. They offer just three options: resection or ablation or transplantation. So, deciding between these three options, we need to look at all these factors: the size of the tumor, the number of the tumors, the location of the number of tumors, if the patients have portal hypertension, functional evaluation of the liver, ICG retention test, etc., comorbidities, and the feasibility of transplantation. It is extremely difficult to cover all the examples for BCLCA and the choice between these three options. We'll discuss two common examples. A solitary hepatocellular cancer, 3 centimeters, AFP 400, in a 50-year-old male without comorbidities and an excellent performance status, with a HPV related CLD, a CTP A5. No significant portal hypertension, and patient is affordable for liver transplantation, lives in a country where donor constraints are absent. Patient A has a tumor here, patient B has a tumor here. Now, how will we choose between resection or ablation or transplantation? Of course, transplantation is the best possible option for both the patients because it cures both the hepatocellular cancer and the HPV CLD. Because after removing this tumor, the CLD is going to remain and the patient continues to remain at a higher risk of developing another HCC. So transplantation is of course the best option, the gold standard treatment, but it may not always be feasible in all scenarios. So if for example, if we remove this, the patient is not right now affordable for transplantation and there are some donor constraints. How to choose between resection and ablation? This patient can easily be resected with a left lateral sectionectomy or a left hepatectomy maximum, whereas this patient would require a complex surgery, a central hepatectomy or a right hepatectomy. So this patient can be better treated with resection provided all of the ablation provided all of the parameters are suitable. The an important indication for resection would be if, for example, we resect this tumor, send it for HPR, and the HPR shows microsatellites or microvascular invasion, then the patient has a higher risk than usual of developing an intrahepatic recurrence. Already, the patient has a higher risk of developing new HCCs because of the CLD. Now, because of these pathological risk factors, high risk factors, the vascular invasion satellites, the patient is at a very high risk of recurrence. So, these patients should be considered for an early transplantation. So, this is called an ab initio indication for transplantation. So, if this HPR is going to offer us an indication for transplantation, then resection is considered better. But otherwise, for tumors up to 3 centimeters, both resection and ablation offer equivalent survival. A second example, a solitary HCC of 6 centimeters. So obviously, ablation is not considered for tumors that are larger than 4 centimeters. 6 centimeter solitary HCC in a 50-year-old male without significant comorbidities and an excellent performance status. But one patient has tumors are in the same location, both amenable for a left hepatectomy. Now, this patient has HBV related CTPA5 chronic liver disease without significant portal hypertension, whereas this patient has a HBV related CTPB7 CLD with varices on esophagus, UGI scopy, collaterals, and splenomegaly, signifying portal hypertension. So this patient will not be able to tolerate resection as well as this patient A. So, minimally invasive surgical techniques are considered better than open surgical techniques and are being considered in patients with portal hypertension. There are no definitive cutoffs for portal hypertension when surgery is absolutely contraindicated, but it is well known that patients with portal hypertension do not tolerate surgical resection well. So, this patient may be considered for an early transplantation, but whereas this patient can be considered for a resection, though transplantation remains the gold standard treatment for both.